is a lecturer, as we all know, at the University of the West Indies Hospital and Department of Community Medicine and Psychiatry, and he did a fellowship in drug abuse at Johns Hopkins University. Without further ado, over to him.
Just to share with you some local research findings, and I'm very happy to say for the last 5 years we don't need to be using US-based and UK-based because we've been doing the work at the University of the West Indies. So I'll just share some of these with you from our own work in the detox unit, which I run at the University Hospital. To begin with, some national schools drug survey comparing 3 different surveys, 87, 97, 2006. Alcohol in this country, like everywhere else in the world, is the most abused substances. And in this case, we're looking at lifetime prevalence. When you look at prevalence, we look at lifetime use in the last year or use in the last 30 days. This slide is about ever used. Again, nicotine, the next substance in terms of most abused. Very interesting that in our country, the prevalence of cannabis misuse approximates that of nicotine. Nowhere else in the world does that happen. Nicotine is usually way up there, away from cannabis, including in the United States of America. And then, of course, for the first time in 2006, we coded for BD, which is a nicotine-containing product. So if you now add the BD column to the nicotine column, then you see that we're really having major problems in these areas. For the first time in 2006, we coded for seasoned spliff, which is a cannabis cigarette with crushed crack cocaine sprinkled in it. You see that we have a major problem if you put that column on top of the crack cocaine column. And so we're not looking good. And when people stand up to suggest that we add yet a third substance as legal, then I really wonder if they have this kind of information at their hands. Separating the nicotine lifetime prevalence, males from females, looking at 97 and 2006, 10 years apart. The purpose of this slide is to show that girls are approximating boys in drug use and in almost all substances. Here again, inhalant, we see where girls are approximating boys, and overall, it's increasing compared to the study 10 years prior. Cannabis lifetime prevalence, again, you see the columns approximating each other. Girls, again, are approximating the use of boys. Specifically, in terms of the trends in the prevalence of cannabis over those 3 different studies, 10 years apart, we see, looking especially at past year and past month use, that we're not only not being successful at holding things the way they are, but they are moving upwards. And so that's a major challenge. It doesn't mean you're not doing any work, but it means more people are using. Why then would you want to make it more available? Another plug against decriminalization of cannabis. Season spliff lifetime prevalence, girls approximating the prevalence of boys. Crack cocaine, similarly, where specifically for crack cocaine, we've had an almost 100% increase in the prevalence of girls in particular. Any legal drug, and this is alarming, because it doesn't happen anywhere else in the world, any legal drug in these youngsters, it's a 50% prevalence. That's a big problem. Some other studies, age of onset, we were interested knowing those magic ages, and so we looked at an adolescent clinic that we had, primarily boys, like everywhere else in the world. Age of onset, age 13, the mean age of onset. And you remember the magic figures I told you, 13. So we have major problems. Drug of onset, you'll never see this slide in any other country in the world. Drug of onset for any other countries, cigarettes or alcohol. In this particular group at the detox unit, the drug of onset in 3/4 of these youngsters was cannabis. When you present these in international conferences, they don't believe, because they can't imagine that there's a country where 3 in 4 youngsters will start by using cannabis, not alcohol or cigarettes. And then, in the interest of time, I'll just forward to that made us curious about the age of onset for the adults. And so we went through the adults for a whole year in the detox unit. Same picture, age of onset, 16 years for cannabis, 18 years for nicotine, 20 for alcohol, and for crack cocaine, 26. So it's very clear that we're progressing from cannabis use to other things. And so the powers that be need to be aware of these issues to certainly get very serious about what they want. You can't be saying, let's smoke less cigarettes, but let's free up weed more. Somehow seems to be a disconnect to me. Drug of onset, similarly, You don't see a picture like this anywhere else in the world. This is now adults would be almost equally the same for cannabis and nicotine in half of the sample we looked at. And I'm just forwarding some of these slides in the interest of time. We looked at comorbid psychiatric disorders. 1 in 3 persons, like everywhere else in the world, coming to the detox unit were identified as having another psychiatric illness. A very important issue of cannabis and madness, I couldn't leave here without covering that. The whole issue of co-occurring substance misuse and mental illness, cannabis-induced psychotic disorder specifically. The questions then would be, is cannabis a cause of schizophrenia? A resounding yes. You separate these causes into sufficient, necessary, or component cause. Cannabis is not a sufficient cause, so it's not enough in and of itself to create a psychotic episode. You must have the genetic predisposition, vulnerability. However, at this point in November 2011, we're unable, through genetic mapping, to determine if you are at risk in terms of your genetic makeup for having a psychotic illness, because we're not sure which genes code for madness. It's not a necessary cause because people get psychotic even if they didn't smoke. But what cannabis is a component cause along with a conglomeration of other insults, for lack of a better word, like exposure to rape, major trauma otherwise, and the genetic predisposition. And now on top of that, you put cannabis, then while you otherwise would have escaped, precipitate the illness in those persons. But because we don't know if you're at risk, then you're certainly taking a chance. And so, in terms of cannabis use in Jamaican adolescents, potentially catastrophic implications. Early initiation of cannabis use, followed by later initiation of cocaine use, is a well-known phenomenon in terms of cocaine exposure opportunities and sexual practices. We need to educate our children that ganja can make you mad. Why take a chance? In any case, smoking anything is hazardous to your health, even if it was paper, wood chips, dried cabbage leaves, and so on. The adult outcomes of cannabis use, we know, certainly is a function of the age of initiation. The earlier you start, the more likely you are to progress to the problems. It's a function of the pleasure of response. If when you smoked initially, you felt really great, then you're more likely to have major problems. You're likely to earn less money as adults. These are well-known studies, and it's quoted on the bottom left of the screen. Reduce educational performance, and likely to be addicted to cannabis and another drug by the time you're 21. Educational measures are very important. Certainly, we spoke to the role of exposure. We would recommend that GPs ask their patients about, especially youngsters, their chances to use, not if they've used, because they're likely to misrepresent the truth. Whereas if you ask for chances to use, if I've seen cocaine or have friends who use cocaine, then I'm at risk. And so that's what we recommend that you ask, and then that should be a red flag where the response is positive. Prevention plays a major role. I'm sure you'll agree, based on all I've covered, that drug addiction is a preventable disease and drug abuse is a preventable behavior. Again, in the interest of time, I just mentioned the different levels of treatment available in the country. The only inpatient unit at the University Hospital, the detox unit, many patients need to come in. Almost all alcoholics need to be admitted as an inpatient. Almost certainly all cocaine addicts and a number of cannabis-dependent persons. So we try with cannabis as outpatient, where it's not working, if the individual is clear that they should not be using for the reasons I discussed with them, and they're unable to at month 2, 3, I then recommend inpatient treatment. There's a Patricia House, which is a short-term residential program for 8 weeks. There is William Chamberlain, run by the Salvation Army, a 6-month program on Lyndhurst Road. Then there is Teen Challenge, which is a long-term rehab, anywhere from a year to 18 months. The longer you're immersed in treatment, the more likely you are to remain drug-free. We now know a magic figure with that is 6 months of engagement. And then, of course, we couldn't leave out the drug court, which offers treatment in lieu of being incarcerated for minor offenses. RISE provides formal addiction alert, major prevention measures in our country. Major problems with adolescents, there is no residential treatment facility for adolescents other than the detox. And so we stretch their inpatient time to 4 weeks to facilitate longer engagement, but we can't keep them there for, they require required 6 months. And so that's a major problem. Community-based prevention certainly is the way to go. Time doesn't allow me to expand on that here. The premises of community-based prevention would include the fact that communities share knowledge about perceived risks to community functioning. Community norms regulate most lifestyle behavior and would play a major role in training succeeding generations. And so at this time, because the vast majority of the average Jamaican parent doesn't have this kind of knowledge, we then need to be working with both, or should be working with both, to eventually in 20 years' time deal with those who are new persons in terms of drug use. Certainly the targets of prevention would be the parent, the child, the peer group, and of course by extension, the community. Different levels and methods of treatment, we're all involved as key players in the prevention and treatment of substance misuse. Food for thought. Alcohol has gone through the gate. Does society really need another intoxicant? If we relax cannabis prohibitions, how do we deal with underage smoking cannabis smoking when we still have no effective controls on underage ethanol or tobacco use? I want to thank you very much.